Welcome to another episode from the Veterinary Medicine Digest. So imagine a 1,000-pound animal, right? One that is hardwired by literally millions of years of evolution for just explosive flight.
Right.
And now imagine that animal waking up halfway through a brain scan inside this multi-million-dollar helium-cooled magnet.
It is literally the definition of a nightmare scenario for any clinician.
Exactly. And if you are tuning into this deep dive today, you probably already know we are bypassing the basics. We are tearing right into the primary article by Dr. Gabriel Manso-Díaz.
Yes, the paper on advanced imaging of the cranium and cervical spine for equine neurologic disease.
Right, and we're cross-referencing it with the latest pharmacokinetic data on contrast media plus some targeted spinal therapeutics. Our mission here is to figure out not just what we can see inside the equine central nervous system, but the fundamental physics and biochemistry that actually make seeing it possible.
Because this paper really forces us to confront the fact that veterinary imaging at this massive scale is basically a hostile collision. It's a collision between advanced physics and just sheer biological mass.
Yeah, you're constantly fighting the inverse square law of radiation, right?
Exactly. Plus the signal-to-noise limitations of magnetic resonance and, of course, the staggering biomechanical risks of the patient themselves. I mean, the logistics alone completely dictate the standard of care.
So let's talk about those logistics. Let's say you have an adult warm blood presenting with acute ataxia. Your gold standard for the central nervous system parenchyma is obviously MRI, right?
Oh, without question. MRI is the absolute gold standard there.
But to actually put that animal in a closed-bore, high-field magnet, you have to use general anesthesia. And you are inducing this massive hypotensive state in an animal whose own body weight is just actively crushing its dependent musculature.
Right. The hydrostatic pressure within those muscle compartments can very easily exceed capillary perfusion pressure,
Which initiates a massive ischemic cascade, I assume. So you might solve the neurological mystery, but then you wake up to a fatal post-anesthetic myopathy.
which is exactly why the decision to anesthetize for an MRI is never taken lightly. And even if you do accept that massive risk, you are immediately fighting the scanner's geometric constraints.
Because human MRI gantries are designed around human shoulder widths, obviously.
Right. So in a heavily muscled equine patient, particularly those crusty breeds like Andalusians or giraffes, the shoulders physically hit the edge of the gantry, and they hit it before the caudal fossa even reaches the magnetic isocenter.
Wait, really? So the part you actually need to see doesn't even make it to the sweet spot of the magnet?
Exactly. The cerebellum and the brainstem, which are the exact regions you often need to interrogate for vestibular or proprioceptive deficits, are just sitting out in the periphery of the magnetic field. And out there, the B0 homogeneity completely falls apart.
Oh, wow. So you just get severe dielectric artifacts and signal dropout right where the pathology actually lives.
You do. So to mitigate that risk, the veterinary field has aggressively adopted cone beam CT.
Right. So shifting from standard multi-detector fan beam CT to cone beam. And that changes the entire physical paradigm of how we actually acquire the volume, doesn't it?
It is a brilliant difference in acquisition geometry. With traditional multi-detector CT, you are essentially painting the target with a tightly collimated laser pointer. You acquire data in these thin helical slices as the patient translates through the gantry.
Okay, let's unpack this for a second. So traditional CT is sort of like slicing a loaf of bread one piece at a time, but cone beam is like taking a 3D mold of a whole chunk of the loaf all at once.
That is a great analogy. Cone beam CT relies on a highly divergent pyramidal X-ray beam. It irradiates a massive volume of tissue simultaneously and captures all that data on a large area flat panel detector.
So you are no longer painting with a laser, you are just illuminating an entire landscape with a single wide-angle flash.
Exactly. A single 360-degree rotation captures a full 150-millimeter volumetric stack in under 60 seconds.
Wow. And that speed has to be the clinical trump card here. A 60-second acquisition means you completely bypass general anesthesia, right?
Yes. You use alpha-2 agonists for standing sedation, load the horse into the stocks, and literally just spin the gantry around the standing patient.
But, I mean, there has to be a catch. The physics of that wide-angle flash must come with a brutal penalty for the contrast-to-noise ratio.
It absolutely does, because you are irradiating such a massive volume of tissue all at once without that tight collimation. You generate an enormous amount of Compton scatter.
And the scatter-to-primary ratio in cone beam CT is, what, an order of magnitude higher than fan beam CT?
Easily. And that scattered radiation hits the flat panel detector and just acts as a massive veil of noise. It completely degrades the low contrast spatial resolution.
I mean, I know the Feldkamp-Davis-Kress algorithms used to reconstruct these cone beam volumes are incredibly sophisticated. But they can't just magically recover tissue differentiation that was lost to scatter, right?
They cannot. So while cone beam yields these spectacular isotropic voxels for high-density cortical bone, it fails catastrophically at differentiating the subtle Hounsfield unit variations between gray and white matter.
Or isolating early-stage parenchymal lesions, I'd imagine. So that physical limitation brings us directly to the black box of the cranium.
Exactly. Let's look at when an equine patient presents with severe recurrent seizures.
Yeah, the limitations of our imaging modalities really dictate our diagnostic confidence there. Manso-Díaz's retrospective study has this staggering statistic on cranial MRI utilization for seizures.
The 84 case study, right. What did they find?
Out of 31 horses presenting with recurrent seizures, only 2 demonstrated visible structural brain abnormalities on a high-field MRI. 2 out of 31.
Wow. But, it perfectly illustrates the concept of cryptogenic epilepsy in this species.
Right, where the electrical software is glitching, but the hardware looks perfectly fine.
Yes. We are looking at a functional excitotoxic cascade at the cellular level. It's basically a storm of aberrant action potentials propagating through the cerebral cortex.
But the macroscopic hardware, like the actual cytoarchitecture of the brain, remains morphologically intact on the scan.
Exactly. But the fact that 29 out of 31 scans were negative does not invalidate the MRI at all. It actually validates the exclusion protocol.
Because you have to rule out these space-occupying lesions.
Right.
I mean, your therapeutic intervention changes entirely if you find a pituitary pars intermedia macroadenoma compressing the diencephalon.
Or a metastatic melanoma infiltrating the cortex. Without the T1 and T2 relaxation profiles provided by MRI, you are essentially flying blind.
Treating the electrical storm while ignoring the physical tornado causing it?
Right. And the necessity of specific modalities becomes even more rigid when we transition from these cryptogenic conditions to acute cranial trauma.
Because the timeline of the traumatic brain injury completely dictates the physics we need to leverage. Like in the acute phase, the first 3 to 24 hours following a massive impact.
In that acute phase, the primary pathological targets are complex basilar fractures and acute hemorrhage, so CT is the undisputed requirement there.
Right, because fresh hemorrhage is distinctly hyperattenuating on a pre-contrast CT.
Exactly. The retraction of the clot increases the physical density of the hemoglobin molecules, which pushes the Hounsfield units well above the surrounding parenchyma.
So you can instantly map the epidural or subdural hematoma. But wait, if CT is so great for acute trauma, why does the Manso-Díaz paper strictly advise switching to MR later? Like, past the 48 to 72-hour mark?
Because the pathophysiology evolves. By day 3, the initial hemorrhage becomes secondary to the catastrophic development of perilesional edema.
Oh, I see. So you're tracking cytotoxic edema where the neurons themselves swell up because the sodium-potassium pumps fail?
Yes, and also vasogenic edema, where the blood-brain barrier breaks down and allows plasma to flood the extracellular space.
And CT simply does not have the contrast-to-noise ratio to delineate that subtle increase in free water content.
No, it doesn't. This is where you have to rely on specific MRI pulse sequences, particularly fluid-attenuated inversion recovery, or FLAIR.
Ah, FLAIR. By applying a 180-degree inversion pulse, you selectively null the signal from the free-flowing cerebrospinal fluid in the ventricles, right?
Exactly. With the normal CSF rendered completely dark, the trapped, bound water of the cytotoxic and vasogenic edema remains highly hyperintense.
So it just lights up the exact margins of the swelling, which I guess allows you to calculate the risk of transtentorial herniation.
Precisely, and that exact precision is also why CT retains its absolute dominance in the osseous pathology of the skull.
Right, like with temporal osteoarthropathy, or THO.
Yes, the anatomy of the temporal apparatus is incredibly dense and morphologically complex. You have the stylohyoid bone articulating with the petrous portion of the temporal bone, all superimposed over the tympanic bullae.
And when that joint undergoes osteoarthritic ankylosis, it basically forms a rigid bridge of bone, right?
It does, and the mechanical implications are devastating. Every time the horse vocalizes or swallows, the movement of the tongue and larynx acts as a biomechanical lever against that fused joint.
So the petrous temporal bone eventually just fractures under the cyclical loading.
Yes, tearing the adjacent facial and vestibulocochlear nerves in the process. Standard lateral oblique radiographs of the skull are almost useless here due to the superimposition of the mandibles and the base of the skull.
So you need the isotropic voxels of a modern CT for multiplanar reconstruction. You can slice right through the petrous temporal bone in any arbitrary plane.
Evaluating the exact thickness of the stylohyoid proliferation and tracing the microfractures propagating through the temporal bone.
Wow. And we see a similar necessity for spatial and contrast resolution in the paranasal sinuses. I was amazed by how MRI can differentiate a simple mucocele from a cholesterol granuloma or an ethmoid hematoma.
It almost feels like a cheat code, doesn't it? The soft tissue differentiation of MRI is unparalleled.
It really is. A cholesterol granuloma packed with breakdown products like methemoglobin exerts significant paramagnetic effects, so it fundamentally alters the local magnetic field,
Shortening the T1 relaxation time and producing a strikingly hyperintense signal on a T1 weighted sequence.
so you can basically diagnose the biochemical composition of the mass before the surgeon ever picks up an osteotome.
Yes, but even with high-field MRI or multi-detector CT, the inherent tissue contrast is often insufficient, especially when evaluating blood-brain barrier integrity or identifying highly vascularized neoplastic margins.
Right. Sometimes tissues just blend together, so we are forced to chemically alter the patient's tissues, which brings us to the chemistry of contrast media.
The Nelson 2017 paper provides an exhaustive look into the pharmacokinetics and the inherent risks of this process. Let's focus on the CT side first, utilizing iodinated contrast media.
Okay, so the physics here rely on the K-edge of iodine. Iodine has an atomic number of 53, placing its K-shell binding energy at roughly 33.2 kiloelectron volts.
Which perfectly aligns with the mean energy of a standard diagnostic X-ray beam.
Right, so when the X-ray photons hit the iodine circulating the vasculature, they trigger a massive spike in photoelectric absorption. The iodine literally absorbs the beam.
Creating brilliant hyperattenuation on the final image. But achieving diagnostic enhancement in a 500-kilogram patient is a complete logistical nightmare.
Here's where it gets really interesting for you as a listener. If a human needs a tiny syringe of contrast, injecting a 1,000-pound horse must require basically a fire hose of stuff, right?
You are not wrong. The standard systemic dose is 600 to 880 milligrams of iodine per kilogram of body weight. You are utilizing power injectors to force liters of highly viscous contrast into the jugular vein.
Just hoping a fraction of it maintains a tight enough bolus through the pulmonary circulation to actually perfuse the cerebral vasculature.
Exactly. And the physiological stress of that volume is immense, which makes the shift to intra-arterial injections such an elegant workaround.
Oh, so by utilizing ultrasound guidance to catheterize the common carotid artery, you inject a fraction of the total volume directly into the cerebral arterial supply.
Yes, you bypass the pulmonary dilution entirely. However, because you are only perfusing one hemisphere at a time, you often require simultaneous bilateral carotid injections to evaluate the entire cranium.
Even so, that reduction in total volume must drastically reduce the risk of contrast-induced nephropathy, which Nelson highlights as a primary limitation.
It is the primary limitation. We have to look at the specific molecular structures of these agents. Early generations relied on high osmolar ionic monomers.
Right, and when injected, those dissociated into charged particles, generating an osmolality, 5 to 8 times higher than normal blood plasma.
Exactly, and that massive osmotic gradient acts as a physiological vacuum. It rapidly pulls intracellular water right into the intravascular space,
Triggering acute endothelial damage, vasodilation, and severe hemodynamic shifts, I'm guessing. So the industry pivoted to non-ionic isoosmolar dimers, such as iodixonal.
Yes. By linking two triiodinated benzene rings together without allowing dissociation, you match the osmolality of plasma perfectly. It's much safer.
But that biochemical safety comes with a purely physical cost, doesn't it? Viscosity.
It does. Those large dimer molecules create immense fluid resistance. When that highly viscous bolus reaches the renal cortex and is filtered into the proximal convoluted tubule, it fundamentally alters the rheology of the tubular fluid.
Because the increased hydraulic resistance slows the transit time of the filtrate through the loop of Henle.
Precisely. Which creates a lethal cascade for the kidney. Because the filtrate is moving so slowly, the medullary cells are forced to increase their oxygen consumption to maintain active ion transport over a longer duration.
Wow, so that triggers prolonged local hypoperfusion. And if the horse has any subclinical dehydration, that viscous traffic jam leads directly to profound renal medullary hypoxia.
And acute tubular necrosis. The imaging agent intended to save the brain can absolutely destroy the kidneys if the patient's hydration status isn't aggressively managed prior to the scan.
That is wild. But, we've eliminated the brain and skull, but many neurological issues don't start in the head, they start in the neck. So let's travel down the cervical spine.
Yes, because the cervical spine presents an entirely unique set of biomechanical and imaging challenges.
If you've ever attempted to interpret a standard cervical radiograph of a heavily muscled warm blood, you know the absolute frustration of the superimposition problem. It's just a mess of overlapping shadows.
It really is. The cervical vertebrae are massive, complex geometric structures. You have the large articular process joints, the transverse processes, the prominent ventral crests.
All wrapped in the dense mass of the longest column muscles. And when you collapse that complex 3D geometry onto a 2D detector plate, the divergence of the X-ray beam casts the contralateral structures directly over the ipsilateral anatomy,
Resulting in a cacophony of overlapping radiopacities. You lose the ability to accurately measure the intravertebral sagittal ratio.
which is the critical metric for diagnosing cervical vertebral compressive myelopathy, or CVCM, often called wobbler syndrome.
Exactly. We can suspect spinal cord compression based on plain radiographs, but we cannot definitively prove it. This diagnostic gap, however, has been entirely bridged by the advent of ultra-large bore CT scanners.
We are talking about gantries with internal diameters up to 90 centimeters. You can advance the entire cervical spine and the cranial-thoracic region of an adult horse straight through the isocenter.
And because the X-ray tube and detector array are rotating around the patient, the reconstruction algorithm mathematically eliminates all superimposition.
Giving you true isotropic cross-sections of the spinal canal. But standard non-contrast CT only maps the osseous boundaries, right?
Yes. The spinal cord and the surrounding cerebrospinal fluid attenuate X-rays similarly. They appear as an undifferentiated soft tissue mass within the canal.
So to quantify the exact degree of medullary compression, we must perform a CT myelogram.
That's right. And the technique demands absolute precision. Under general anesthesia, you perform an atlanto-occipital puncture.
Advancing a spinal needle through the nuchal ligament and the duramater directly into the subarachnoid space.
Yes, and then you inject the isoosmolar non-ionic contrast medium. You take advantage of the natural caudal flow of the CSF to outline the spinal cord.
So on the resulting transverse MPR images, the subarachnoid space appears as this brilliant, hyper-attenuating ring of white, with the spinal cord itself sitting as a dark, unenhanced core.
Exactly. If osteoarthritic proliferation of the articular process joint, or maybe hypertrophy of the ligamentum flavum, is compressing the cord, you literally see that brilliant white ring of contrast become effaced or obliterated at that exact millimeter.
But the true breakthrough here, the real revolution of the 90-centimeter bore, is dynamic myelography, isn't it?
It absolutely is, because the biomechanics of CBCM are rarely static.
Right. A horse might demonstrate perfectly normal subarachnoid clearance when the neck is positioned in a neutral, extended posture on the CT table.
But the moment you actively flex the neck, tucking the chin toward the sternum within the gantry tube, the biomechanics of the cervical vertebrae shift.
Especially at the mid-cervical articulations like C3, C4, C4, C5. As the neck flexes, the vertebrae can actually subluxate.
Yes, the dorsal aspect of the vertebral body drops into the spinal canal, violently compressing the ventral aspect of the spinal cord.
And running a continuous acquisition during that active flexion allows us to capture the transient obliteration of the contrast column.
Proving that the dynamic instability of the joint is the direct mechanism of the ataxia.
But what happens when the spinal cord itself is fine, but the tiny nerves exiting the spine are getting pinched? Like, the diagnostic narrative kind of fractures when you execute a flawless CT myelogram. The subarachnoid contrast ring is pristine from C1 to T1, yet the horse presents with an obscure, intermittent forelimb lameness.
That is a frustrating scenario for everyone involved.
So what does this all mean for the owner? Let's say you have a horse with a forelimb lameness, a limp. Vets block the hoof, the ankle, the knee, the shoulder. Nothing fixes it. Are you telling me a leg limp is actually a neck problem?
In these specific cases, yes. You are describing the classic presentation of cervical radiculopathy.
Wow. So the pathology is not localized in the main trunk of the spinal cord, nor is it in the distal limb.
No, the pathology is localized at the intervertebral foramen. That's the microscopic osseous window, where the individual spinal nerve roots branch off the cord and exit the vertebral canal.
Think of it like a localized voltage drop in an electrical grid. The main high-voltage transmission line, the spinal cord, is functioning perfectly.
But right at the local substation where the line branches off to supply a specific neighborhood, in this case the forelimb, the transformer is crushed.
Right. The resistance spikes, the voltage drops, and the end user experiences erratic power.
Right.
The brain registers the corrupted efferent signals from that pinched nerve root and interprets it as catastrophic pain in the distal limb.
Exactly. It is referred pain originating from a proximal impingement. And the 2024 paper by Wood and colleagues represents a massive paradigm shift in how we isolate and neutralize that specific impingement.
Because historically, resolving IVF compression relied on generalized, blind corticosteroid injections into the adjacent articular process joints, right?
Yeah.
Just hoping the anti-inflammatory payload would diffuse ventrally into the foramen.
Yes, and the Wood paper proves that assumption was fundamentally flawed.
Oh, really? How do they prove it?
Using high-resolution CT, they demonstrated that global enlargement of the APJ, specifically secondary to advanced osteoarthritis at the C6 and C7 levels, physically intrudes into the margins of the intervertebral foramen.
Oh, wow. So the osteophytes directly impinge upon the exiting nerve roots.
Precisely. And because they mapped the exact millimeter coordinates of the impingement, they realized that intra-articular injections were missing the target entirely.
So they pivoted to a highly targeted extra-articular approach utilizing advanced ultrasound guidance.
Yes, utilizing an 18-gauge, 15-centimeter echogenic spinal needle to navigate the complex fascial planes of the caudal neck.
I mean, the acoustic windows required for this must be incredibly narrow.
They are. The radiologist is driving a 15-centimeter needle past the transverse processes, maintaining a trajectory medial to the jugular vein and lateral to the carotid artery.
Just to reach the ventral rami of the cervical spinal nerves, the VRCS ends.
Correct. On ultrasound, these nerve bundles appear as distinctly hypoetoic linear structures wrapped in highly echogenic perineurium.
And by visualizing the needle tip resting directly against the epineurium of the inflamed VRCSN, they injected a targeted payload of triamcinolone acetonide.
Yes, and the biochemical mechanism of that injection is just beautiful. Triamcinolone doesn't just mask the pain.
Right. It halts the inflammatory cascade at the genetic level. It binds to cytosolic glucocorticoid receptors, translocates into the nucleus, and actively upregulates the expression of lipocortin-1.
Which is brilliant because that protein suppresses phospholipase A2.
Immediately shutting down the release of arachidonic acid from the cellular membranes of the inflamed nerve. You completely halt the synthesis of prostaglandins and leukotrienes right at the site of the mechanical impingement.
And the clinical efficacy of that precise biochemical blockade is profound. Out of 47 VRCSN injections performed across 12 horses in the study, 9 demonstrated statistically significant improvement in their lameness grading.
That is amazing. And even more crucially, for the clinical application, 8 of those 12 horses returned to their previous levels of athletic performance, right?
Yes, we are talking about high-level eventers and show jumpers whose careers were considered completely over due to intractable radicular pain successfully returning to competition.
The statistical power of that outcome completely validates the entire premise of this deep dive. You cannot achieve those clinical metrics with blind therapy.
No, you cannot resolve a 2-millimeter nerve compression deep within the cervical musculature without the isotropic spatial resolution of CT to map the osteophytes and the real-time acoustic feedback of ultrasound to deliver the triamcinolone.
It really is the absolute pinnacle of targeted precision medicine in a 1,000-pound patient.
Absolutely. And if we extrapolate these current capabilities into the immediate future, the trajectory is very clear. We are rapidly approaching the complete dissolution of the boundary between diagnostic and therapeutic imaging.
Wait, what do you mean?
Well, currently, we utilize the cone beam CT to map the pathology, then transition the patient to the ultrasound suite to execute the injection. Within the next decade, we will see the integration of real-time robotic tracking within the CBCT gantries themselves.
Oh, wow. You're talking about the CBCT software not only mapping the narrowed intervertebral foramen, but actively calculating the optimal needle trajectory, and then basically guiding a robotic arm to deliver a regenerative biological payload.
Exactly. like mesenchymal stem cells or autologous protein solutions delivered directly into the perineural space while the horse simply stands under light sedation.
That is wild.
Yeah.
You completely bypass the limitations of acoustic impedance in ultrasound and eliminate the need for human hands to navigate the fascial planes.
It's incredible. The physical absurdity of managing the equine central nervous system has historically been our greatest limiting factor. But the necessity to overcome that immense biological mass is driving veterinary imaging to engineer solutions that rival, and in some aspects actually pioneer, the advancements we see in human neuroradiology.
It's an astounding realization, really. I mean, we started this discussion acknowledging the terrifying logistics of placing a massive, flight-driven animal into a high-field magnetic resonance scanner. And we walk away understanding how that exact challenge has catalyzed a level of technological and biochemical mastery that is completely redefining what is medically possible. Thank you for listening. The titles for the reference papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.